per capita income in the state, and there's a federal formula that looks at per capita income in all of the states and across the nation, and each state's proportionality to the average national per capita income then determines their FMAP. So as you can imagine, that adjusts over time. Currently, North Carolina is in a period where our per capita income is increasing at a faster rate than the nation as a whole, and what that means is that the federal match has been going down. And you can see we are due for another downward revision as of October 1st of this year. So it'll go from a little over 65% down to 64.62%. There is also something we call an enhanced FMAP for that certain services for certain children draw. It's associated with a federal children's health insurance program. That's about 75%. That also adjusts annually. And then finally, there's the services for the Medicaid expansion population. That draws a 90% federal share. That's the same across the country, and that's a stable amount. That doesn't change unless Congress changes it. As far as support from the state side, the traditional Medicaid population does get a general fund appropriation. The expansion population gets funding through a special fund and we'll talk about the funding for the expansion population later, but it's largely from hospital assessments. The state share that's not funded from the general fund then comes from a number of other departmental receipts. The one you may be most familiar with or may have heard the most about is hospital assessments. There are some other provider fees, provider transfers, and also some special funds that help to support the state share. So eligibility for Medicaid. When a state agrees to have a Medicaid program, you don't have to have a Medicaid program, but every state does. The federal government then requires you to cover certain mandatory eligibility groups, and some of these are not surprising. For example, the age, blind, and disabled group, children, newborns up to, from households with incomes up to 196% of the federal poverty level have to be covered. Children after they reach 1 year, children have to be covered up to 133% of the federal poverty level, same with pregnant women. So you can see some of those mandatory groups there. There are also some optional beneficiary groups. And the biggest of these right now is the expansion population. So these are the adults 18 to 64 up to 133% of the federal poverty level. And that's your expansion population that, as we'll see in a minute, is now more than 600,000 individuals. All the other populations that you see on this slide as far as optional beneficiaries, as well as all the mandatory beneficiaries from the prior page, all of those are part of what we consider our traditional Medicaid population. To enroll in Medicaid, an individual would go to their county Department of Social Services, or currently the state also has authorization from the General Assembly to use the federally facilitated marketplace that was set up with the Affordable Care Act. And that federally facilitated marketplace, it's temporary authority to use them to determine Medicaid eligibility. That temporary authority ends June 30th, 2025. So that's something that the department may be asking to extend that authority at some point or perhaps make it permanent. But that's an authority that at this point is set to expire. County departments of social services also do Medicaid redeterminations, so most populations have to be redetermined every 12 months. During the COVID pandemic, so really it was about close to 3.5 years where the state couldn't drop individuals from the Medicaid population. As a result, obviously, the Medicaid population grew, I think it was by roughly around 700,000 individuals, and that population remains elevated, and there is still a backlog of redeterminations that the county departments of social services are working their way through. So currently there's more than 3 million beneficiaries. And on slide 10, we show a slide of this, and you can see that for a number of months after the COVID pandemic ended and people could begin to be dropped from the Medicaid rolls, that traditional Medicaid population, which is the lighter portion of the bar, was dropping down and declining. It sort of leveled off over the last couple months, while of course the Medicaid expansion population has been growing. And that's not surprising as a newer program in the state that we're building towards and would expect at some point for that population to plateau. So as far as the benefits that are available to Medicaid beneficiaries, similar to the eligibility group, there are certain services that the federal government mandates that you have in your Medicaid program. Many of these are not surprising. So things like physicians and nurse practitioners, hospitals, ambulance or medical transport. There are also some optional benefits that the state has agreed to provide. It may surprise you that prescription drugs, for example, are not a mandatory benefit in Medicaid. Now, every state does cover prescription drugs through their Medicaid program, but it's not a mandatory benefit. Another one that I'll point out is personal care services. These are services that help individuals, vulnerable individuals with activities of daily living, for example, grooming and bathing and eating. And those are services that the Medicaid program provides. Most Medicaid programs provide, but it's not a mandatory benefit. Another thing to keep in mind is that not all services are available to all Medicaid beneficiaries, and the best example of this is the family planning eligibility category only receives services related to family planning. The Division of Health Benefits has the authority to set clinical coverage policies and reimbursement rates for most Medicaid services. When they're making adjustments to those things, they have to make sure that they stay within their budget. And since July 2021, most Medicaid beneficiaries are now enrolled in a Medicaid managed care plan, which takes us to the Medicaid transformation discussion. So prior to managed care in North Carolina, the way things were done was a fee-for-service basis, which each service provided by a provider would receive reimbursement directly from the Medicaid program. So the difference with managed care is the state now pays a managed care entity a per person, per month amount, and then the managed care entity is responsible for coordinating, managing, and paying for the health care for those beneficiaries. Obviously, then the prepaid health plans, as we call them, contract with a network of providers. North Carolina has had managed care in behavioral health for more than 10 years. It may actually be approaching 20 years, but the changes that were made in 2015, the legislative changes bringing about Medicaid transformation, offered a more comprehensive managed care plan that included both behavioral health and physical health. So I've put in the next slide, slide 16, some pieces of that 2015 Medicaid transformation legislation. One of the important things was to provide budget predictability and ensure quality for the Medicaid beneficiaries. And you can see specifically the legislature spelled out some goals of moving to managed care, which was to ensure budget predictability, to balance quality and patient satisfaction with financial measures, and you can see some of the other things, but I think with respect to the budget, the thing that gets called out a couple times really is the predictability of managed care. So some of the prepaid health plans currently in North Carolina, and we'll start with the standard benefit plans because this covers most Medicaid beneficiaries, about 73%. There are 4 statewide plans plus 1 regional plan that's available to about half the state. So beneficiaries in the standard plans get to choose from 4 or 5 managed care plans. Again, that's the largest group in managed care. The tribal option is the smallest group. I believe there are about 5,200 individuals in the tribal option, but this is unique to North Carolina, that it's an Indian managed care entity, and it's an option only for members of the Eastern Band of Cherokee Indians. One of the interesting things with that is it does draw a 100% federal match for qualifying Eastern Band providers. After the standard benefit plans, the next largest plan is the behavioral health and intellectual developmental disabilities tailored plans. That was launched last July. And there are approximately 230, maybe 240 now enrollees in that plan. It's about 8% of the total population. And those are individuals specifically with more severe behavioral health needs, so mental illness or substance abuse issues, and the intellectual and developmental disability population. The LME MCOs hold the contracts for those tailored plans. And finally, there's a children and family specialty plan. This will be available to about 30 or 35,000 people. The expected go live date for that is December of this year, and that will be a single statewide plan that's run by Blue Cross Blue Shield. And then some populations will remain in Medicaid fee-for-service, which we also call NC Medicaid Direct. On the next slide, I show some of the capitation rates. These are the capitation rates currently being used, or they're sort of an average of what's currently being used. And you can compare the standard plans to tailored plans. So we talk about giving managed care entities a per member per month amount. It's not quite that simple because it depends on what type of beneficiary it is. Obviously, the managed care plans get more, for example, for an age blind or disabled individual than they would for a child or a non-disabled adult. But providing this to give you sort of a flavor for those capitation rates, and I've tried to line up the populations as best they can be lined up between the standard plans and tailored plans, and not surprisingly, an equivalent group in the tailored plans is going to be more expensive and draw a higher capitation rate than somebody in a standard plan. Moving on to some enrollment data. And on slide 20, the sort of medium blue color that you see there is all the standard benefit plans, and you can see where the enrollment is. In the bottom right corner, then you can see the tailored plan population and which LME MCO. Therewith, you can see a small share of for the tribal option. All the solid rectangles that you see are managed care, and then the stripes is those populations that remain currently in the fee-for-service Medicaid. So one of the populations you can see there is the Children Family Specialty Plan, CFSP. By the end of this year, that population will be in managed care as well. On slide number 21, I show a breakdown of the total Medicaid population. You can see that children make up the largest group. If we were to look just at the traditional Medicaid population and not include expansion, children would make up, I think, close to 60% of the total. But since we now have expansion, the expansion members are now included with other Medicaid adults receiving full Medicaid benefits, and you can see that the adults make up about 30% of the population. Then you have about 15% that are age blind and disabled, and then we do also have an other category, and you can see it's noted at the bottom what makes up that other category. But it's basically the partial benefit individuals. I think the more interesting thing about this slide is on the right, and you can see who's in managed care. And the children and adults without disabilities, about 97% of those groups are actually in managed care at this point. It's a lower percentage of the age blind and disabled group. On slide number 22, I try to put some of the spending out there. So this is $17.5 billion in service spending through the first 6 months of the current fiscal year. So this is based on actual data, and I think really the biggest takeaway is just how much. It's 75% now of the spending that's in capitation payments. There is still fee-for-service, and the Medicare payments, that's paying cost sharing and premiums for members who are dually eligible for Medicaid and Medicare. Some of them we pay the premiums and cost sharing, the Medicare premiums, Medicare cost sharing, and we also pay the federal government for some portion of the Medicare Part D benefit that the federal government offers. So that's what makes up the Medicare payments. I think there's a lot that we could talk about on this slide. We could spend a lot of time on this, but I'm going to move past it for now in the interest of time. And move on to the Division of Health Benefits budget. So we're looking at a 5-year chart here, and I've broken up the bottom part of the chart. The dark blue is the federal receipts, and you can see I've cut the chart at $10 billion also, so you can imagine that dark blue goes down further than what you see there. There's also other receipts, so these are other state receipts that the state uses to help pay for the Medicaid program. And then the top portion is the general fund contribution to Medicaid. And I feel like there's a story that I could tell with each of these different bars, but I'm going to focus really on two trends that you see here. The first is the last couple years, you see some pretty large spending increases, right? But mostly what that is, and we'll see this actually a couple slides from now, but that's adding in the expansion population and adding in the healthcare access and stabilization program, which was to provide higher managed care reimbursements to hospitals. But you'll see in a couple slides that those two programs make up a significant part of that overall increase. And importantly, those two programs don't require additional general fund appropriations. That being said, the other trend that I want to point out is that the general fund contribution has gone up, and that's the general fund contribution specifically for the traditional Medicaid population. The reason for that, during the COVID pandemic, every state received an additional 6.2 percentage points on their federal Medicaid match. That addition was phased out during calendar year 2023, requiring the state then to make up the money that the federal government had been putting in. The other thing that's changed, as I mentioned at the outset, is our base FMAP has been dropping at the same time. So while our base FMAP was at 67%, or maybe a little above 67% a couple years ago, we're now down at 65%. Doesn't sound like a big change, but when you're talking about billions of dollars, it makes a big difference and does increase then the general fund contribution. On the next page, this is sort of a continuation from what we talked about yesterday, that the largest portion of the budget for the whole department really is aid and assistance. Same is true for Medicaid. You can see these are significant percentages, and you could definitely make an argument that the transfers and carry forward, probably at least most of it shouldn't be counted here either, in which case you'd be up around 97, 98% of the budget that goes towards aid and public assistance. Keep an eye in the second year there on the administrative costs, $518 million, because that's what we'll talk about on the next slide. So that $518 million on the left, you can see how that breaks down as far as personnel and some other costs. But I want to give you an example of some of the contract costs, because you see that clearly makes up the biggest part of the administrative budget. So those contracts would include things like actuaries, project management, the managed care enrollment broker, assistance with program design, evaluation, readiness reviews for new managed care plans that are set to be implemented. So there's a lot of different things. I'm sure the department could probably give you even more examples of what those contracts are. Then if we move over to the pie chart that's on the right to see how those administrative costs are being supported, and you can see most of it is federal receipts. So the federal government, most administrative things draw a 50% federal match. There are some that draw a higher federal match, but overall the $518 million in administrative costs, 55% is paid with federal receipts. You can see about 1/5 is paid with general fund, and then there are some other receipts. But over the last several years, the state has used the Medicaid Transformation Fund to support administrative costs in the Division of Health Benefits. That fund is now empty, and so there's a question, and those it's all non-recurring money as well. So that's something that the General Assembly is going to have to consider with respect to the administration budget for the division. Let's talk about some of the significant budget actions from last biennium. So the biggest thing really was Session Law 2023-7, the Access to Healthcare Options. Most people will know this as the Medicaid expansion bill. So that's one of the things that the bill did. It expanded Medicaid and established a financing structure for expansion that's made up of receipts from a new hospital assessment that was put in place, and also the additional gross premiums tax that would be collected from the prepaid health plans as a result of expansion. So it's basically then a self-supporting program. And there are now more than 600,000 expansion beneficiaries. Another thing that legislation did was establish the Healthcare Access and Stabilization Program, or HASP, which increased Medicaid hospital reimbursements. Hospitals for this program pay the state share for those increased reimbursements, but you can see at least last year that was a benefit to the hospitals of somewhere around $2 billion. And then finally, that legislation also established the ARPA Temporary Savings Fund to hold money from a Medicaid expansion incentive that was part of the American Rescue Plan Act. And so far, more than $1.5 billion in savings has been transferred or will be transferred into that fund for projects around the state. And those projects include capital projects. They include a number of behavioral health projects. They include some things to bolster the healthcare workforce. So that money really was spread around for some of the General Assembly's priorities and initiatives. On slide 29, we look back again at a 5-year spending history. And here's where I think it's important that the bottom portion of this chart shows the spending for the traditional Medicaid program. And here you can see that the growth in spending over the last couple years really has come from the expansion population and the Healthcare Access and Stabilization Program. And then, of course, there are transfers to that ARPA Temporary Savings Fund. What I'm illustrating here is just, despite the fact that we've seen these increases in Medicaid spending, most of it is for programs that are supported not with state general funds, but programs that are self-supporting. Some of the other major actions from the 2023 Appropriations Act, increased reimbursement for nursing homes and personal care services, cost the state $161 million annually, increased provider reimbursement rates for behavioral health services, approximately $75 million annually. These are the general fund costs. And then there were also some initiatives with respect to innovations waiver as well. Some budget considerations for the upcoming fiscal year and upcoming biennium. First and foremost, probably supporting the Medicaid rebase and fiscal research. Our early estimates, we haven't seen a governor's budget yet to look at the rebase, but we're estimating about $500 million for the first year of the biennium. And then on top of that $500 million, an additional $310 million the second year for $810 million rebase in the second year of the biennium. Another thing you'll probably have to think about is funding to replace the administrative support from the Medicaid Transformation Fund. I know Deputy Secretary Ludlam is going to talk about the updated 1115 waiver, so I won't go into the details here, but hopefully he'll speak to that more. There'll be implementation of the Children Family Specialty Plan that's scheduled for December. And then some of the things that have come up the last couple years are more comprehensive or broader Medicaid provider reimbursement rate adjustments, and also support for Medicaid direct care workers. So I think all of those are things that you may hear about during the upcoming biennium. And with that, Mr. Chair, that concludes my presentation.
Thank you, Mark. We'll have you back for questions after Secretary Ludlam. Would you like to introduce the staff with you today? And then you can make your presentation from your seats. Thank you.
Yeah, thank you very much, Chairman. Good morning. My name is Jay Ludlam, Deputy Secretary for North Carolina Medicaid. With me today, I have Melanie Bush, our Deputy Medicaid Director, Adam Levinson, the Chief Financial Officer for North Carolina Medicaid, and Julia Lurch, who is our Chief Actuary and our Chief Strategy Officer. The four of us have worked together here at North Carolina Medicaid now for, I think, almost 6 years total, though some have worked with the department or here in North Carolina for even longer than that. So I will begin my presentation then. Again, my name is Jay Ludlam, and I am the Medicaid Director here in North Carolina, and I love my job. This is one of the most exciting opportunities for me to be here today to share with you the hard work that our staff have done to support North Carolina and the health of North Carolinians. Part of what I like about my job so much is that I get to meet with members, individuals in the community, providers who are serving and supporting those people in our program. We're able to talk to, on a daily basis, people who have access to health care for the first time in their lives through Medicaid expansion or through the program that we run. We support direct care workforce who are themselves supporting individuals who are trying to live within the community, trying to remain and get healthy at home. And so those are really, really impactful conversations that we get to have. We're able to go to the openings of clinics that are now able to provide behavioral health services in communities that may not have had access to that. And that's all because of the work that you all have guided us and directed us to do. So it is a fantastic opportunity. I am also lucky because I get to talk to other states. Other states come and talk to North Carolina because of the work that you all lead. They want to know how it came that North Carolina has made large investments in behavioral health, recognizing that you can't arrest your way out of a behavioral health crisis, that kids in schools need supports now more than ever to address mental health issues. They also want to know how it is that we focus so much on preventative care for children. Our new initiative coming up, the Children and Family Specialty Health Plan, is already something that other states are envious that we have begun the foundation of supporting broader reforms to support children in their families and in community. We also, of course, have one of the leading programs on how to address the underlying social risks that people face in food insecurity and housing insecurity and the inability to get to work or school. And we have figured out solutions that rely on local community-based organizations here in North Carolina to support not only the individual health of those communities, but also to be resilient in the face of disasters like we had this fall with Helene. And most recently, of course, we've received a lot of questions from states that want to know how North Carolina figured out how to expand Medicaid and expand it in the way that we did, where we were able to get people cards in hand on day one. I think it was about 270,000 people who qualified for the program. We were able to get their card in hand, and we were able to immediately start having an impact on their ability to manage chronic disease, their ability to get access to dental services that they wouldn't have otherwise been able to get. And it is, again, through your leadership that we have been able to support rural working people here in North Carolina. We've been able to do so much with the investments that you've made. And as Mark said, we have done it in a way that we've tried to bring a business mentality. We've tried to use data to drive our decision making, and we have a lot to talk about. So without too much further ado, Mark kind of highlighted this and appreciate the presentation that he gave. Sometimes I don't envy the work that he has to plow for us in terms of laying the foundation. But what I will say is that we work very hard to stretch limited state dollars to improve the health of more than 3 million North Carolinians. And again, support the financial stability of rural providers. As Medicaid, as a program, we find ourselves to be the largest payer of mental health services in North Carolina, the largest payer of substance use disorder treatment, long-term care services, and almost 50% of births are on the Medicaid program. We play a critical role, as Mark highlighted, in the sustainability of hospitals, community health centers, of course, physicians and nursing homes. And with your support, we have been able to use innovations, really first of its kind innovations here in North Carolina to reduce demand for costly interventions in an attempt to lower the cost curve. And I think that this is some progress that we have really made over the last number of years. We now are seeing the data to support the impact of these programs that we have all worked on over the last 6 to 8 years. We are particularly excited about the opportunity to launch the Children and Family Specialty Plan. We'll talk about that in a little bit more detail. But again, this is part of a larger reform effort at the department and remains the #1 priority for Medicaid in this coming calendar year. I put this slide up not to frustrate everybody in the room because of the small little numbers and words on this page. I'm really trying to highlight that what we have here is a dashboard, or a picture of a dashboard that is up on our website. And so I'm going to encourage you and your staff to take a look at this. It is an interactive dashboard. You can click on various counties. There are other tabs that allow you to look at particular programs. How many standard plan members who are with AmeriHealth Caritas are in your community? You'll be able to see that through this interactive dashboard. And so the link is at the bottom. This is part of our effort to be transparent about our performance, transparent about the impact of the program, and so that the people of North Carolina and, of course, the General Assembly can see the work that they're investing in. North Carolina Medicaid, let me back up. Not everybody outside of North Carolina realizes that North Carolina is the second largest rural population in the country. And so it would not surprise anyone to know that Medicaid benefits rural North Carolina, that we have an outsized impact on rural community. Robeson County, 62% of the residents of Robeson County are on Medicaid. And as you can see, the numbers are quite large, and there is, it does drive a lot of our approaches to making sure that we are communicating and supporting rural communities as they try to access our program. Medicaid expansion, very similarly, has a tremendous impact on rural communities. I believe our rural population in the state is a little under 20% of the total population, but in Medicaid expansion, it does account for about 38% of the population in the Medicaid expansion benefit. So this is, again, another interactive dashboard that is available on the website. We update this on a monthly basis. Mark touched on this a little bit, but it's just an important item to highlight. Sometimes it's easier to count the number of individuals and believe that reflects, the potential cost. That may have been true in the past, but I think right now what you're seeing is that while 79% of the Medicaid population are families and children, those families and children account for less than half, or 46% of Medicaid expenditures. Some people may not realize that for older adults and people with disabilities, while they account for 21% of Medicaid enrollment, they are approximately 54% of our expenditures. And so this is something to just be aware of, that Medicaid does play a critical role in long-term care and supporting older adults as well as people with disabilities. In addition to responding to the Helene disaster, one item that we were really working on was finalizing the extension of the original 1115 waiver. So to cast your mind back, when we were able to originally negotiate the first 1115 waiver under the first Trump administration, we have obviously been implementing that over the last 4 years or 5 years, and so we had to renew it. Some core components that are inside of that 1115 waiver, it continues the authorization for our managed care programs. This is the standard plan program, which we launched on July 1st of 2021 in the middle of the pandemic. We then launched just this past summer the behavioral health IDD tailored plans on July 1st of 24. And the 1115 waiver does provide us the authority to launch the Children and Family Specialty Plan, which is targeted for December 1st of 2025. I want to note, and I'll probably say this again in a few slides, but when we get to the point of launching the Children and Family Specialty Plan, we will need to continue to work with CMS to demonstrate that the plan is ready and that we are ready to serve North Carolina with that program. And so this authorizes the creation of it. It does not necessarily authorize the implementation. And so that will be the continued work that we'll be working on this year. There are new options or opportunities for this, for the General Assembly to consider supporting. One is the statewide expansion of our successful Healthy Opportunity pilots. Again, I'll talk about this in just a second, but we did take the approval of this 1115 waiver opportunity as a good sign that we are on the right path and that we're doing the right work in supporting local communities, but most importantly, the health of those participants in the program. We also have the option to work with local counties on a program to do less frequent redeterminations for children, which allows those counties to continue to focus on adult redeterminations. So a little detail we'll talk about probably this year or over the next 2 years is that our local DSS offices do the applications and the redeterminations for the majority of Medicaid beneficiaries. So for those, so counties do that work. The work is hard. It takes as much time to process a adult redetermination as it does to process a redetermination for a child. However, adults cost 2.5 times the cost of a child in our program. And so what we have seen is that in order for us to continue to maximize the value of the limited resources we have at county offices, that we have worked on automation as well as policy flexibilities that allow them to deem children as redetermined. We did use data to come up with the support for this policy. What we saw was that 80% of children were redetermined eligible after going through the entire process. Of those 20% that were terminated and removed from the program, 25% of them came back within the first 90 days. And so the real value here is in having this the local county staff focused on adult redeterminations. Another initiative that was presented to us is the opportunity to support jails and prisons in care managing those individuals who will be released back into the community to provide services to support them around substance use disorder and other needs that they may have as they re-enter the community. And this is an option that we'll want to talk about whether or not and how we would like to do this moving forward. We also have another component where we're trying to support behavioral health workforce and do better coordination in our data system, so a technology component. So we look forward to having further conversations about these 1115 waiver options. We were asked to come back and present a little bit about the launch of the tailored plans this summer. The launch was generally very successful. We put the tailored plans through a very rigorous readiness review process. As this committee knows or may know, there were times when we actually had to say no-go because for particular reasons, we felt that the department or the plans themselves might not be as ready as we needed to be as a system. We worked very closely with them, and they were very successful, and in fact ended the readiness review process on day one. They had closed out all of their readiness items, which was something that was the first time in our launching of managed care programs. We focused very hard on minimizing the disruption of members and their families who needed to now have new primary care providers in the tailored plans. We wanted to make sure that these families were able to keep their care teams together, and so that was a big area of focus for us. We also went through a very rigorous testing of their systems. We call it, user interface testing, system integration testing, and end-to-end testing. These are all really important to make sure that providers can get paid on day one, that the pharmacy claims go through and people can get needed pharmaceuticals again on day one. And so we went through a very intense process. I will say and report to the committee that it has been largely very quiet with this launch. I do want to acknowledge the unbelievable pressure that the system was under in the fall. Not even 95 days after launch, the Hurricane Helene hit the West. VIA in particular was obviously directly affected, being the primary health plan in that area. Partners was also similarly affected. Both were incredibly resilient in supporting local community, but also, we didn't hear about a lot of claims issues during this time. There was really good performance out of the health plans throughout all of that. And again, this was really just days in the way we measure time in Medicaid. It was just days after we had launched, really. And so real hats off to the organizations. They all came together, all four of them came together to work together in supporting Western North Carolina. So real kudos to all of them. I think we were also asked to present a little bit about Healthy Opportunities. Healthy Opportunities is, again, we have an option to go statewide with this program. This is the first of its kind program where we're able to use Medicaid match. So, in many of the areas that you may do appropriations, it's just state dollars. We are able, through our negotiations with CMS, we are able to get match on our investments in this program. So we get service match for the actual delivery of services, and then we also get a portion of the cost, about half of the cost, of helping community-based organizations ramp up in preparation for delivery of these services. We're able to get a 50-50 match on that. What that's allowed us to do is launch some very innovative programs that support local communities and just for the committee to see, this is a map of all of the various counties that are participating in the program. We have 3 network leads that were competitively procured a number of years ago: Access East, Community Care of the Lower Cape Fear, and Impact Health. These organizations work with local community and identify the needs of those local communities. They also work as an intermediary in supporting community-based organizations and getting paid through the managed care program. The impact has been real, and we have seen it in these limited areas. So again, this has been a pilot, 33 counties. We only started this almost 3 years ago, and so a very short time frame. We have currently about 40,000 Healthy Opportunity pilot enrollees. We have delivered over 800,000 services. The impact of this has again, has been real. We have lowered healthcare expenditures, we estimate approximately $1,000 less per Healthy Opportunity enrollee per year, and that actually includes the delivery of services. And so this is going to be the housing supports, or the food supports, or the wraparound services to address interpersonal violence. The reason why there are savings is because these programs reduce and decrease emergency room visits, for example. And so while 6 per 1,000 may not sound like a lot, when you think about the investment of a food box or some other low-cost service against the high cost of an ER visit, you don't need many ER visits to really have an impact. But we are seeing these real impacts. We're also seeing a reduction in inpatient day stays. If you are healthier, if you have a full belly and you've had good nutrition, you are able to recover from surgeries more quickly, and you're able to not get as sick the next time. What this means is that by reducing the risk of food insecurity, housing instability, and the lack of access to transportation, what we have seen is an actual impact on those counties and those regions where the capitation, we forecast that the capitation rates will be lower in Healthy Opportunity pilot regions than those regions that don't have healthy opportunities. And this offsets the new dollars that would have otherwise been needed. And I just have to say, conversely, if Healthy Opportunities were not to continue, we would expect that the costs of Medicaid managed care in those regions to increase. Because again, we would expect ER visits to go up, and we would expect inpatient days to begin to lengthen, and other services would have an impact as well on those rates. I'm going to now talk a little bit about the Children and Family Specialty Plan, and while she doesn't have a placard with us, Deputy Secretary Susan Osborne is here with us, representing a broader initiative at the department, and this is what we in Medicaid often play the primary role, but here we are playing the support role in helping launch the Children and Family Specialty Health Plan. The Children and Family Specialty Health Plan is part of a larger effort that I think we're all engaged in here at the General Assembly, as well as at the department, in strengthening North Carolina's child welfare and social services system. And the purpose is to improve the outcomes for children in safety, permanency, and well-being. And as you can see, we put a star next to it, but we intend to launch the Children and Family Specialty Health Plan, and we'll talk a little bit about some of the details. But I do want to share, this is, again, part of a broader initiative, and I'm just going to highlight some of the other strategies that we are working on at the department in partnership with the General Assembly. We intend to update the Child Welfare Information System, PATH-NC. We're providing financial supports to unlicensed kinship providers to increase the number of foster care involved youth who are placed in kinship care. We are expanding the professional foster parenting approach. We're implementing a regional support model for social service agencies to deploy continuous quality improvement and technical assistance to more effectively and efficiently across the state. And we are building capacity for local DSS managed crisis stabilization and assessment placements. So again, this is the Children and Family Specialty Plan is not the end point. It's a piece of a larger strategy. So a couple of details. We have worked on this a number of years together, and there are some essential differences. We intend to launch on December 1st of 2025, and then continue to mature the system afterwards. This is not something that we will cross the finish line and be done. This is something that we will need to keep running and supporting over time because there is need in this space. But this is going to be an important component where we have the statewide contract we awarded to Healthy Blue coming together over the summer. We are working with them right now on developing and doing the work to implement. We will then engage in the readiness activities that we've highlighted, and this is in part why we'll want to talk to you about continued funding for those dollars to support these implementations. This program will require significant coordination across multiple agencies, both within the department as well as outside of the department. And in full transparency, this is going to be the complexity. We've launched health plans. We are working with a partner that we know. They are Healthy Blue is a standard plan partner, but the complexity is going to be getting these organizations that I have here and others within the community to work together in different ways so that we can continue to advance and mature and support children through these reforms that we're trying to implement. Our focus is person-centered and a family-focused approach to care delivery. Our goal is to preserve families. We know that that's not possible in every situation, but in the longer run, that will be a big focus of ours, and we'll come and we'll talk more about that. Our goal is to prevent entry and re-entry into the foster care system and support reunification and other permanency plan options. The benefits are going to be largely familiar to folks. They are going to be all of the services included in our standard plan program, and then many of the services that are currently in our tailored plan program. And like I said before, the coordination between these organizations, not only from a system governance perspective, but on the ground in local DSS offices, we'll be we'll do a lot of work together with Healthy Blue, local DSS offices, and the department on care management and coordination model, connecting these offices and all the various entities that are trying to support these children and these families in a difficult moment. All right. My predecessor would have called this the elephant in the room, but I wanted to highlight we're in the news. I think last night there was a vote in the House, but we do know that there's a lot of conversation, not only here in North Carolina, but all across the country, as there are potential cuts to the Medicaid program. We do want to highlight, and I think Mark did a good job of highlighting how much we receive in federal match, how much we leverage existing authority to run volunteer provider assessments and various programs to support and extend those limited state dollars. We do anticipate, up to a potential $27 billion in federal cuts in North Carolina. That I don't know that it would be all of the federal match, but it could really change the way that the program is configured. In a typical year, 98% of North Carolina Medicaid expenditures are for services and payments to providers. The reductions we anticipate would have an outsized impact on rural communities. And of course, there is a component of the expansion, I'll call it the expansion law, but North Carolina's Medicaid expansion coverage will be discontinued if the federal match rate does fall below 90%. There are more than 630,000 North Carolinians who would lose coverage, that they only got coverage maybe 15 months ago, that more than over $6 billion would be lost in additional federal funding related to that. And we talk about it in our office. People will not stop getting sick. What will happen is, like a balloon, if you squeeze the balloon and you no longer allow for certain services to be paid for in one setting, the balloon will expand in the other setting, probably the ER, the emergency room, and there will be an increase in uncompensated care, or individuals will fall back into the traditional Medicaid program. So welcome conversation about these potential cuts, and I think that's the presentation, sir.
Thank you. I appreciate that. We'll move on with some questions here. I have a quick question, Mark. Under the FMAP, as our state does better and we lose, let's just say 1%, how much does that equate in state dollars to replace the federal dollars?
Thank you, Mr. Chair. It's a good question. So for every 1/10 of 1%, that's equivalent to $18 or $19 million in general funds. So your example was 1%, that's $185 million then.
Thank you. Representative Chairman White.
Thank you, Mr. Chair. Mr. Ludlam, I have two questions. In a thumbnail, could you say the major difference between the current foster program and the foster program that you desire in this new design? And I see you looking at Ms. Osborne, so I was just being courteous to you since you were the one who presented them. And, you know, I know that that's a big ask, but for people in the room, we have a lot of new members and stuff, and if we could just do a little thumbnail, what do you all see and hope from what we've got currently now in the foster care program, because we've worked on this for a very long time with you all, and thank you so much for your effort to do this.
Thank you, Representative White, for that question. Susan Osborne, DHHS. So I can do it in a thumbnail. Provides more services upstream for families. That prevention part that Deputy Secretary Ludlam talked about, the services that will be offered will be more upstream. We will have every child enrolled in the plan will have a care manager. The previous system, you had to apply for care managers for the more complex children. So a care manager that will follow the child, and a care manager that's embedded in the community. Third, this is statewide. So as children had to leave a county to be safe and receive what they needed in a placement, that required moving between catchment areas. This will allow streamlined, immediate access to services they need without a single case agreement or a reaccreditation of a provider. And I think the other is an intentional focus on closing that rural-urban divide with how we offer services to families. So that's my thumbnail, and I would.
Thank you, Senator Bergen.
Thank you, Mr. Chairman. And if it's all right, I've got 2 for Mark and 3 for Jay, but I'll ask them really quick.
You're recognized for a series of questions.
Okay. Mark Collins, first, is there any clawback provision? You know, all this redetermination, we went for almost 3 years, didn't do any redetermination. We know that a lot of people that were on Medicaid went back to work, so they were back on their health plan, but at the same time we were paying the preferred health plans for that coverage. Is there any clawback provision, or how does that work? Is there any way to get any of that money back, or does it, as someone told me, it works out over the long run, but I still haven't figured that
So there's no clawback that I'm aware of. And I don't know if Jennifer Hillman can comment too, but there's no clawback that I'm aware of.
Thank you. I believe she's not aware either.
Okay, thank you, sir. May I follow up?
Yes, sir.
Also, the folks that are still in fee-for-service, is there any mechanism, I mean, fee-for-service, we got away from it because it was fee-for-service. Is there a way to move those folks into other populations? Managed care, specialty plan, any other way to get them off of fee-for-service? I was looking at the total number there, and so we're running multiple operations.
Right, and thank you, Senator, for the question. It's a good question. I think for the most part, at least the large populations that are currently in fee-for-service, that's the intention that's written into the state law. Now, there is an idea that eventually some of the dually eligible individuals, so the individuals who are eligible for both Medicaid and Medicare, will eventually be moved into managed care. That's a longer term process. But yeah, if we look at this 5 years from now, 10 years from now, we may see even more in managed care, but there will continue to be, for example, the Medicaid Family Planning Program, what we call the partial dually eligible population, that as the law reads right now, they are not part of managed care, and you probably wouldn't want them to be part of managed care.
Thank you, Mr. Chair.
Thank you.
Deputy Secretary Ludlam, is there a way to track the folks that are involuntarily committed to a plan to see, like if I wanted to know if there's 800 people that are involuntarily committed today in our hospitals across the state, is there a way to see how many of those are on a tailored plan and who they're with, who they're assigned to?
Jay Ludlam, Deputy Secretary, North Carolina Medicaid. I would like to take that back. I don't know what data we would have to indicate that in our systems, but if that's all right, I'd like to take that back.
Yes, sir, that'd be great.
Okay.
Follow up. Could you get us, all of us, a list for last year of the top 10 most expensive Medicaid cases? And what information we can have that's not a HIPAA issue, but like sex, age, don't want to know location or anything, but I'm just curious. I've gotten that in the past, and I think everybody be interested in seeing the top 10 most expensive Medicaid cases last year.
I think, again, Jay Ludlam, North Carolina Medicaid. Sir, I think that so long as it's not personally identifiable,
yes,
you know, we would work to get some kind of insight into those 10 people. Sure.
Last question. And I guess this is really for you and Mark. Let's say that we are cut $27 billion. Are you all working on a contingency plan?
Again, Jay Ludlam, North Carolina Medicaid. We are putting a lot of thought into what is currently happening. I think right now our focus is continuing to support the program that we have, continuing to support members. Our number one priority right now is the Children and Family Specialty Health Plan. As the process works itself out, I think we'll get greater clarity from Congress as well as from the General Assembly here on guidance and direction on where to go with the program from here. Can I just offer two potential explanations or answers to the questions that you asked Mark as well? So you asked a question about clawback, and built into the Medicaid program is the rule. I think it's a rule, or if not a statute, that requires Medicaid to act as the payer of last resort. So if those individuals that you were describing did have other insurance through their employer or through some other means, while also on Medicaid for whatever reason, because again, Medicaid is a income-based program, not a whether or not you have insurance program. And so if somebody did have other insurance, there would be a requirement either for the Medicaid managed care companies or for the division to coordinate claims and effectively either cost avoid and not even pay the claim because they have other insurance and direct the provider to bill the other insurance, or to recover those funds. So that's already built into the system and would already be accounted for in our budgeting requests, as well as the Medicaid managed care rates.
Okay. No, I'm fine, thank you.
Keep me from being one of the 10 most expensive medical cases of the thing. I overlooked Representative White for a follow-up, so.
My next question was, but I think it's good that Senator Bergen was recognized, and because this is a redetermination question as well. Based on what we now know that I think you said today that redetermination is kind of overdue for some number of people. Do you have any estimation of how many people are receiving current Medicaid services that have not been redetermined, and about for how long has that redetermination not been done? And I know that's a broad, and if you don't have the answer today, I can wait, but I would like to know an estimate.
Ms.
Yes.
Bush, you recognize.
Thank you, Mr. Chair. Melanie Bush, North Carolina Medicaid. We have numbers from December of 2024 that shows that 84% of our adults have had a redetermination in the last year. So that leaves about 16% that are still not determined. Jay spoke to this earlier. One of the flexibilities that we did implement to allow our counties to focus on adult redeterminations, because they are more expensive, is that we have been extending children. So quite a number of our children still remain unredetermined, about 55%. That will end on June 30th of this year. We will no longer be extending those children unless we implement our continuous eligibility for those children. So about 16% of adults still haven't been redetermined as of December. Obviously, January and February is almost over, so that number has gone up closer to 90%.
Thank you. And what follow-up?
Yeah, we've got 6 people and I've got 4 minutes.
Have a second. So of that 16%, then the second part of my question was, how long has that been like 2 years that they were not redetermined, and this is just the number we have now, or that was just for 24? Mm-hmm. Okay, thank you.
Did you ask that too?
Yeah, you got it.
Who's going to answer?
Charity Day.
Okay, thank you. Senator, sorry.
Thank you, Mr. Chairman. The question for Deputy Secretary Ludlam, I think, or Mark Collins maybe. The 630,000 people that are part of the expansion population of Medicaid, has the department done any sort of study or data analysis to determine how these people are receiving health coverage prior to the expansion going into effect? I mean, we hear oftentimes this was the uninsured population, but now that we're kind of on the other side of that hill, have we looked into that, determine whether all 630,000 were uninsured or they're receiving it from some other means?
Yeah, again, Jay Ludlam, Deputy Secretary, Medicaid. A lot, just to bring the committee back, the work that we were doing in 2023 as we got closer to launching Medicaid expansion, we had just started what is called the continuous coverage unwinding. And what that means is that, for example, on day one, we were able to use information in our systems to see that about 270,000 people that were receiving receiving care through either our family planning benefit or would have been redetermined ineligible under the old rules were now qualified for Medicaid expansion. And so I think that to your question, as people are redetermined throughout 23, throughout 24. Many people were on Medicaid to begin with during the pandemic and then moved to Medicaid expansion. And so I would estimate that largely, yes, that they would have been otherwise uninsured. But I don't know if we have additional information. Okay, I think that's what, yeah.
Just a follow-up, I mean, do you have I'll ask for a hard number, but I mean, is it possible to find a hard number of how many people were uninsured prior to the law going into effect versus how many now have insurance after the fact?
Yeah, we can take that back and get those hard numbers for you. Thank you, sir.
Thank you, Senator Sar. Representative Campbell.
Thank you, Mr. Chairman. I want to thank you guys for being here, and I do want to say thank you for the rapidity of your responses when I've asked you questions and for data, and I appreciate that. I have kind of two questions. I'll just put both of them out there to whomever, and then I just have a follow-up comment. First question was, in terms of the COVID holdovers with redetermination, is it correct you said that could represent about 700,000 recipients? And I understand this is a decentralized problem, but when was that task authorized to start, and when will it be over? And then my second question for anybody who wants to, in terms of the managed care plans, what is the auditing and accountability structure for that? How are we overseeing how that's determined? How do providers, if they're noticing difficulties with reimbursement, who do they talk to? And are we looking at to see if the administrative cost of these plans are higher or lower than the administrative cost that if HHS was doing it themselves? So I'll let you answer that, and then I just have a quick follow-up comment.
Mr. Collins, that you can answer. That's a Jimmy Dixon 4-part one question. So you won't be allowed anymore along with Mr. Dixon and Mr. Blackwell. So, but we will answer your question now, Mr. Collins.
Yeah, so I think maybe I can answer, or at least try to answer the first part of that question, Mr. Chairman, and thank you for the question, Representative Campbell. It was July 2023, and I intentionally put this chart that's on page 10 and started it in June. June would have been the peak enrollment for the traditional population, and that's when they began disenrolling individuals, July 2023. So you can see that a number of people have actually come off the rolls since then, but at one time it was about 700,000 that additional individuals who had been on Medicaid due to that during that COVID time frame.
Mr. Ludlam, would you like to answer the second, third, and fourth part of that question?
Yes. Regarding the Medicaid managed care oversight, the department does, the division does engage in oversight of the health plans. We require financial reporting. We monitor claim submissions, which are called encounters, which is a little too technical, but we do oversight and try to reconcile claim payments that have been made with those financial reports that they provide. I think I maybe said we have independent as well as state staff, independent organizations and state staff that monitor the quality of services. We perform what is called the CAPS survey, which is a survey of the experience of providers and beneficiaries in Medicaid managed care, and we monitor that. And so there is oversight of the health plans, and just again to start at the beginning, the competitive process of procurement is the first step towards oversight. We really try to make sure that North Carolina gets the best organizations to work on our behalf. Regarding the administrative cost of health plans, there is an additional cost for each health plan. There's salaries, there's claim systems, there are various other initiatives, and I think as we engage in conversation over the next couple of months about the upcoming reprocurement of the standard plan program, I think that that's part of that conversation.
Yeah, if you'll be quick, we have two more, and I'd like everybody to get an opportunity.
So just that, one thing I'll say is, and I understand when we're dealing with costs, and I'm just giving you this not only as a representative, but as the perspective of a provider who gets reimbursed by Medicaid. We talked about the backlog, and I get that with reassessments and things. Yesterday, we talked about NC Path that kind of followed $120 million expenditure to realize that something didn't work. I know when we look to decrease cost, if any of our federal friends are listening, welcome, and please hear me on this, is that we always talk about how can we decrease the amount we are reimbursing the people that are actually providing the medical care. And as a provider who often is giving care to Medicaid patients, that we are getting reimbursed less than it cost us to give the care. I just ask everyone listening, please, my federal friends, if you are, that when we look to decrease costs, that maybe there are other avenues than just decreasing how much we pay providers for doing services that we are often doing at a loss just to help our community. Thank you, Mr. Chairman.
Thank you, Representative Campbell. Representative Cervania.
Chair, I have questions for the Medicaid and also Director Osborne. So I have many questions, but I'm only going to ask one. I will send a list of questions that are a follow-up with Dr. Campbell's reimbursement rate, the administrative costs for Medicaid transformation, and for Director Osborne, how does the the children and family program help the kids in transition? But my one question for right now is immediate. We get a lot of calls from constituents concerned about Medicaid being lost. And so we need an immediate communication plan and providing the right information from all of you who are getting it and involved in it, provided to us so that we can tell our constituents the right information to quell the fear. So if I can ask that of you all, and if you can respond and how we can receive that at what time frame. Thank you.
Thank you. Representative Boynton.
Thank you, Mr. Chair. So going back to Secretary Ludlam's presentation, I appreciated hearing about the Healthy Opportunities pilot. Very exciting about the impact that's had in reducing medical costs. How long will the pilot last, and are there any plans or hopes to expand the program?
Jay Ludlam, Deputy Secretary, thank you for that question. So we would want to work with the General Assembly on bringing forward this program to a statewide profile. In terms of, and so that, that's going to take some investment, but again, we do see that as a cornerstone to reducing future costs and quote unquote bending the cost curve. Regarding expanding the program, which is a little different in my perspective from moving to a pure statewide, what we are looking at is how do we focus the limited resources on those interventions that have meaningful and impactful I was going to say impactful impact. Impactful impact on the health of individuals and communities, and again, has the best opportunity to reduce future costs. And so what that may require is really a focusing of some of the services, and that's been part of our program, has been just using data to drive decision-making and how we implement the program. But again, we do see this program as having a very positive impact on health outcomes and community economies, and we would welcome the support to go statewide.
Thank each of you for being here. We assume that we'll see you tomorrow, same time, same channel, next Tuesday, Wednesday, and Thursday, and the following week as well. Thank you for all your presentation, to our staff, Mark Collins, to everyone who made this possible. This time the meeting is adjourned.